Okay, welcome. Welcome to the poster presentation session of the 12th International Virtual Dementia Conference. So this year we're going virtual. We would like to welcome everybody today. It's a 2-day conference followed by a policy and practice forum on Wednesday. So we have a full day of presentations and speakers today and tomorrow, and it's on our website, engagingdementia.ie. Sinead Grennan is my name. I'm CEO of Engaging Dementia. I'm stepping aside for a year though, and Kim Tully is taking over. So Kim is also co-hosting the conference today and tomorrow. So you'll see Kim in various sessions. For people who are tuning in, do use the chat or the Q&A function to send through a comment or a question. And then what we might do is manage them all at the end, if that's okay, so that we can go through all of the speakers kind of one after the other, because we have a really rich range of presenters here today. So we're really keen to make sure that everybody has an opportunity to present their poster. So the session is also being recorded. And if anyone uses Twitter, do feel free to use it. Our handle is @EngagingDemIRL, and we have a hashtag DementiaConf20. Our first speaker is Elizabeth O'Donnell.
Hello. So this research is a systematic review of qualitative studies that explores the experiences of care home staff in managing behaviours that challenge associated with dementia. And psychotropic drugs such as antipsychotics are often used to manage behaviours that challenge in care homes, despite being associated with increased risk of stroke and death. So the aim of this systematic review is to identify the facilitators and barriers to implementing a sustainable non-pharmacological approach to managing challenging behaviours. And the protocol for the systematic review was registered at Prospero. The methods involve searching databases, PubMed, PsycInfo, and Chanel, as well as grey literature searches. 1,121 unique records were identified, and studies are included if they explore the experiences of care home staff in managing behaviours that challenge associated with dementia, and if they use qualitative methods of data collection and data analysis. And the CASP checklist for qualitative research was used to assess the quality of included studies. Quality appraisal was conducted by one reviewer, while a second reviewer assessed 20% of records. And thematic synthesis was informed by Thomas and Harden, 2008. 30 studies met the eligibility criteria included in the systematic review from 9 different countries worldwide. There was 3 overarching themes identified: putting out the fires, also the theme personhood, human rights and respect, and finally the theme person-focused approach, a paradigm shift. The theme putting out the fires refers to reactive strategies used by care home staff to quell behaviours that challenge as they occur, with short-term benefits. However, if non-pharmacological strategies fail to be effective, care home staff may use benzodiazepines and antipsychotic drugs. The theme, personhood, human rights and respect, relates to the intrinsic value of the individual with dementia, focusing on their capabilities, cognition, and complex emotions. The final theme, person-focused approach, a paradigm shift, expands on the concept of personhood and reflects on the changes in attitudes, care home culture, and practice required to manage challenging behaviours in a sustainable way to support people with dementia to maintain their capabilities for longer. So here I've included a few quotations from care home staff, which you may find interesting to read, so you can download the poster later and read the quotations from them. So just to conclude, the barriers and facilitators to implementing non-pharmacological interventions to manage behaviours that challenge include care home culture, staff levels, staff turnover, adequate training and skills, and staff knowledge of the side effects of psychotropic drugs. Also, collaboration and equitable decision-making between residents, families, care home staff, especially healthcare assistants, and other healthcare professionals, facilitates a non-pharmacological approach to managing behaviours at challenge without resorting to psychotropic drugs. So I'd just like to thank the other members of my research team, Dr. Caroline Swarbrick and Professor Carol Holland, the Director of the Centre for Ageing Research. And I'll welcome any questions that you may have. So thank you.
Thank you so much for that, Elizabeth. It was very interesting. We covered behaviours that people can find challenging earlier on a little bit, and then tomorrow morning as well. So it's really timely that you are looking at that. So thank you very much. And now I would like to introduce our next speaker, Karen Gorman.
Hello, my name is Karen, and I am the dementia support nurse in the day hospital in Beaumont. So my poster is on the establishment of the dementia support nurse role in the Beaumont Hospital in 2019. So when we started out by looking at what is dementia support nurse, and we looked at the definition first of all. So when a person is diagnosed with dementia, they're often faced with the uncertainties of what will become of them, and these uncertainties are often shared by their family. The idea then is to help a person to cope with that diagnosis, to support their family and to make the most of their strengths, assist them in living through the present and moving into the future. So the aim then was to make sure that it was a person-centered approach, to continue living well with the community, to provide information and support and help the person to manage issues from getting that diagnosis. So as the program should show you there, it was very much about being a patient-centered program. So there's lots of different ideas around the edge of it, but we looked about what meant to the person. So it was, looking at where the person was in their diagnosis and what mattered to them. So the aim was always to make the most of the person's strength, their personal qualities, and their values. So it was very important to provide a calm, safe, quiet environment. And support was through conversation, through goal setting, through tailored strategies. So from my end, it was who are they, what matters to them, and what do they enjoy? So the value of re-engagement through clubs, through hobbies, through introducing support where needed was through really stressed. I worked to actively support them through conversation about the future to whatever extent was appropriate to the person, and help them to recognise what was important to them. And we would have conversations with regard to their diagnosis to whatever level that they were at. We also provided information and support around driving, enduring power of attorney, keeping well issues from alcohol and delirium. In terms of methodology, the post was established from the funding through the National Dementia Office, and this was for 19.5 hours per week, which was 3 days a week, and each programme ran for about 3 to 4 weeks. And the funding was in place until 2020, the end of 2020, but we're very grateful that we've received funding for the next 2 years. The service is located in the day hospital and all referrals are from consultant geriatricians. So in terms of findings, the stats were collected from January to November 2019, as that's the period that was required. And I hope that it shows there that there was growing rate of referrals and also growing attendance, and this was really positive. So from that period, we had 93 people attended with a diagnosis of dementia, and an equal number of family members attended with them. And something that actually was shown was that each of these dyads also had maybe a second or third person attend with them, and that was something that we really embraced and were not expecting. The next slide shows there that something that is always encouraged when people attend is a link in with services. And although maybe it's brought up when they're seen and assessed, but through maybe being overwhelmed with their diagnosis, it's not always taken up on. So that's something that we really work with. And as you can see, there's a growing number of attendance with services. Something that we work with the people is not just actively signposting, but linking them in with the services. We carried out a satisfaction survey, and there was very high satisfaction survey in terms of participant satisfaction. But not only that, in terms of feedback, something that came through was very much high participant satisfaction in terms of listening and also support received. In looking at sustainability, we would have had students from DCU who were public health nurses and also RGNs from Beaumont. And the idea behind this was that they would link in with their own communities and try and develop similar services with the community. So in conclusion, the development of the dementia support nurse role was made possible through the post-diagnostic grant scheme, and it resulted in the development of a new service. The number of referrals is growing and continues to grow. And in addition, it has meant that there has been a new role developed within Beaumont Hospital and has very much become integrated within the Beaumont care pathway. It very much links to the national agenda around provision of early and timely intervention for people living with life-limiting conditions, and is very much part of the National Dementia Strategy. Thank you very much for listening and for all your support.
Thank you so much, Karen. That was very interesting. And congratulations on getting funding to continue with the programme.
Thank you very much.
It's fantastic. Yeah. Okay, I will now introduce our next speaker, Brian McGuinness. And Brian is going to be speaking about applying collaborative co-design and implementation science to inform implementation planning for a dementia redesign project in a hospital setting. Okay, thank you, Brian.
Thank you very much, and thanks for the opportunity to present my poster. So this is based on my thesis from my master's program that I did for advanced practice, becoming an advanced nurse practitioner. So I'd like to thank my supervisor and my tutor. So really what we wanted to do, I want to give a background first of all. So one of my areas is dementia care. And the problem really that we were facing, being an acute hospital, I work in the Mater Hospital, and it's not really equipped, nor is any acute environment, equipped to really care for people with dementia. Whether that's from a clinical environment, the unfamiliar faces that they may see, the distress of having an acute illness. Also that it's come out from the research from the National Dementia Office and the audit in dementia care that was just published recently this year, that there's a need to adapt the clinical environment, and that is increasingly important in the aspect of provision of care in the acute setting for hospitals. So really my intention is to give an insight of the implementation process rather than the project itself, but basically the project aim to design a homely, dementia-friendly space on the acute geriatric specialist ward, which really to provide a relaxed environment for patients with dementia to be able to avail of during their admission to the hospital. And really we had great help from the National College of Art and Design, where students come in once a year and pick various different projects to be able to enhance from their point of view, looking at it from a different creative point of view, from an art and design. So they really took on board this project and enhanced it. It was quite a big project to take on as well. So implementing innovation in healthcare is notoriously complex, and it takes on a lot of factors and influences, and these can be contextual influences. They span across the organization itself from a systems point of view, but also from the people within it from a behavioral point of view. Effective implementation of innovations and best practice requires a systematic approach. So that's one thing that we really had to plan for early on in this project. So this presentation really highlights how implementation science as a method and also collaborative co-design really support a rigorous systematic approach to implementation planning. So the methods that we used, so we really had to do a rigorous assessment. So implementation planning took the form of a formative evaluation study, and this was informed by implementation science. and a collaborative co-design approach, as I mentioned already. I set up a working group, and with quite a diverse amount of stakeholders involved. And this was from all the disciplines, from say the speech therapist to the physiotherapist to nursing to the consultants, psychiatry of old age, the estates department, so on and so forth. The evaluation aimed to generate local evidence and stakeholder perceptions of this new concept in terms of, you know, the influences for implementing this change. And where we really made headway was when we evaluated the ward itself through using the King's Fund, the environmental assessment tool. Is your ward dementia friendly? And this really sold it to the estates department. So it really worked out well from that point of view, and that's one big tool that we had to be able to sell it well. The other thing was using the Consolidated Framework for Implementation Research, the CFIR, and we identified significant barriers and facilitators through using this framework. And one of the major barriers was cost and the complexity of it. We were converting the old day room into a sitting room, and there was various different aspects to this. So the facilitators really was that the Mater Hospital has a really good culture of implementation and good climate for it. And there is a transformation office that we were able to link with, and they really helped in the whole organization of it. So when we identified these barriers and facilitators, we used the ERIC implementation strategies to be able to overcome these and identify key strategies to help with implementing this project. And that's a 73 set of strategies. So we used about 20 of them. And some of them were like what we had done really unbeknownst to ourselves, was setting up a working group, was doing site visits. We went to Connolly Hospital. We went to the dementia unit over in Shankill. We were able to identify champions and prepare champions within the organization as well to come on board, and getting local opinion leaders as well, say through the director of nursing and the CEO, to be able to bring this project to fruition. The results then, and the three big significant influencers in this promoting this implementation process, was getting that leadership engagement. And myself as a middle manager, the AMP role is very much seen as middle management, being able to use my social capital as such, people I knew in the organization, to be able to bring them on board, whether that was having conversations formally or informally on the corridor, stopping the painter as he walked by and discussing what the project was about and getting him on board bit by bit, building up that engagement and forming that coalition, which I mentioned. And that could be anyone from policymakers within the hospital to the frontline staff. We really had to get the staff on the specialist geriatric ward on board as well, get them to see how this would work. There was a lot of skepticism about it, you know, that's going to add to the workload, and who's going to man it, and who's going to make sure the patient is safe within the sitting room. So there was all those barriers and those fears that we had to overcome. And then the other significant influence was really the use of these strategies to be able to overcome the big barrier of funding and the cost that this was going to incur. So really the take-home messages was gaining that stakeholder engagement and commitment. That's crucial to be able to have a pre-planning phase and really driving momentum. Evaluating through formal and informal conversations, getting that network on board, being able to build momentum from that point of view. And then also that the pre-implementation planning framework may be valuable for others conducting similar work. So the use of the CFIR was paramount to be able to structure our analysis and bring forward identifying the barriers and facilitators, using a systematic approach basically and a structure to our plan. So there's some references, and thank you for listening. And just again, thank you to Carmel Davis and Thilo Kroll in UCD.
Thank you so much, Brian, for such an interesting presentation. And it's interesting you connected with St. Joseph's in Shankill. I assume it's St. Joseph's Shankill,
yes,
you were referring to there.
Yeah.
Yeah, they're really a leader in Ireland, really, in the household model of care. So I'm sure it was really worthwhile, a worthwhile contribution to the project. Okay, so I will introduce Emma Finch, and Emma is going to be speaking to us about the implementation of a cognitive stimulation therapy group on a specialist geriatric ward. Okay, Emma.
Hi, so I'm Emma Finch and I'm a senior speech and language therapist and I work in the Matter. So it actually leads on nicely from Brian's presentation as we actually run the group in the dementia friendly sitting room that he was instrumental in creating. So just a little bit of background. So I know that CST was touched on a lot today, but just for those who don't know, it's a non-pharmacological treatment for people with mild to moderate dementia, and it's based on the principles of reality orientation and cognitive stimulation. It was developed by Amy Spector and colleagues in UCL. But just to point out that it's usually delivered in community or kind of daycare settings. It's not typically used in acute hospital settings. You typically have 14 sessions delivered over once or twice weekly and follow a set structure and different themes weekly. We were lucky enough here in the Matter to secure funding from the National Dementia Office grants in 2018-2019 under the Post-Diagnostic Support Scheme that Fiona Keogh touched on earlier. So with this grant, we employed a therapy assistant to help with the setting up of the group. And very luckily, he's since been made permanent after that initial grant. So our group, it runs twice weekly on the specialist geriatric ward here. And as I mentioned, it's in the dementia-friendly sitting room. It's run by myself, my occupational therapist colleagues, and a therapy assistant that we employed initially. So in 2019, we started in mid-February, and we did 77 groups with a total of 102 participants. 2020 for everyone obviously has been a different year, so we haven't done as many groups. We've done 40 and they've started back up now, but at a significantly reduced capacity to allow for social distancing. We try to follow the Making a Difference manual, the CST protocol, as closely as possible, but obviously with some adaptations to make it appropriate for the acute setting. As a speech therapist, I'm interested in looking at how it affects people's communication, the participants' communication. So we do the Holding Communication Scale as an outcome measure. We also have our own pro forma that we use, and this has that we use for every group for kind of documenting it, and that has various different cognitive and communication observations after each group. So this is just a slide just to pick out some of the stats from the group attendees so far. So you can see kind of more females than male. And here is this graph just shows all the different types of dementia that we have had people attending the group. There is, just to point out, this big section here of unknown, and that is just represents those people who we noticed that it was quite challenging in the notes, in the medical notes here, to have their diagnosis written and documented, and I think a lot of sites at the time found similar. Another thing to point out as well is that originally CST was kind of evidence-based for mild to moderate dementia, but we have taken people in the more advanced category and we have seen benefits for them. Another thing to point out, just with it being an acute setting, is that there, very few of the participants will get the recommended 14 sessions. So you can see here, there's, most of the people get under 10 sessions. So that's one of the other differences. So the benefits that we've noted, it really provides that kind of natural communication environment. We've noticed improved orientation for the group members, and we've really noticed an increase in confidence and a richness in their interactions from when they first started attending the group to the end. We've noticed friendships, which I think is really important on an acute hospital. When they don't have lots of stimulation, we've seen people kind of chatting on the ward afterwards, which has been lovely. We've really noticed that change from seeing the person and not the patient, which I think is really important in an acute hospital setting. We've had the staff mention to us that they've noticed reductions in those behaviours that challenge after the group. And then I think really importantly, there's been enjoyment for not only the group members, but for all the staff involved in the running of the group. There have been challenges. The biggest one I would say is the logistical issues of getting them to the room, getting them set, make sure they're not at their different appointments and therapies. And we've made lots of referrals to audiology, so that's been another challenge. And then in particular with COVID-19, not just the social distancing, but also the use of the masks and how that impacts that kind of natural communication and hearing. And as I touched upon, that kind of challenge of recording in the inpatient setting, and we're still looking at the best ways to do that. And then what do we refer to after, especially when they're discharged home from the hospital. In terms of my own reflections, it's been a really good use of clinician time. So myself and my OT colleagues can, see up to 8 people in one group setting, and how that's so important where every contact counts in an acute hospital. We have found that it's possible to tailor CST for an acute hospital setting. We've noticed improvements that I touched upon for those who don't attend the recommended 14 sessions, and really for those with more advanced dementia. And from a professional standpoint for myself, it really does appear that it is a viable SLT communication intervention. And that's mine. Thank you.
Thank you so much for that, Emma, that really interesting presentation. Engaging Dementia has actually been involved in a CST project as well for the past year, co-facilitating one of those National Dementia Office PDS awards, just like yourself. And yeah, our findings were kind of similar. It's going to be covered at the Policy and Practice Forum. So it's kind of tying in nicely with that as well. So now I will introduce Claire Matthews, and Claire will be speaking with us about introducing assistive technology to clients and carers in dementia care. So, Claire.
Hello, so my name is Claire, and I'm going to chat to you today very quickly about a group that I run here in Sligo with a colleague of mine, Kevin McLaughlin. This group, as the title will show you there, is about introducing people to different assistive technologies. And the purpose of this group, or one of the main reasons I decided to start this, is that I purchased some items of assistive technology. It's separate from the memory resource rooms, but I had been to visit quite a few, and I got some ideas about how I would like to introduce that to my own service users that I work with, the mental health services. So I purchased these items, and I was thinking, what's the best way of getting this information out there and learning about this equipment? So it was to increase the people that were attending the groups, their understanding of different assistive technology that's available, but also for me to learn about the technologies as well and what real life experiences people were going to have with it. So it was kind of a book club format. So everybody that attended the group was living with dementia and their care partners. So we had a lot of conversations during the groups about the experiences of dementia and challenges and what solutions people were coming up with. So with those conversations, it was quite beneficial for people. A lot of them are coming quite soon after diagnosis, so it helped with adjustment to the diagnosis. We were also talking about equipment that people maybe didn't need at the moment, but they might down the line. So it created conversations about the future, but in a very positive way and very solution focused way. The groups itself, the way they ran, they took part in a HSE owned house that we own. So it was a sitting room, a very comfortable, intimate environment. We could really only facilitate 3 couples. So there would be 6 people, and then myself and my colleagues, so 8 of us in the sitting room. So it was quite an intimate, very comfortable environment. So a lot of conversations happened quite naturally. People opened up, and people enjoyed that small group number, they said. The way we worked it, prior to each 6-week block, we would do individual sessions with the person living with dementia and their care partner. And in those individual sessions, we would do a kind of an interview to get an understanding of what people's expectations of the group were, what they already knew about technology. At this point, we would also do wellbeing scales with the person living with dementia, and then a carer burden scale with the care partners. And these were repeated at the end of the 6-week block. The group itself would take place, we would demonstrate different items, different pieces of equipment at the start of each session, and then people would take away, they would pick what they wanted to take away for the week. They would get a feedback form or a usefulness questionnaire, we called them, where they would rate each item out of 10. They would say whether they thought they'd buy it, if they thought it was value for money, if they thought it was useful, if they'd recommend it to somebody else. And then the following week, each couple would come. So they were very much the experts in this format, and they would come back and tell us what it was like to use these items in real life. And from that, then those feedback or usefulness questionnaires, we photocopied them, and everybody would get a copy. Everybody had a folder in which we would have information about the items of technology in it, and also then a copy of everybody's usefulness questionnaire. So the expert knowledge, we managed to keep that and share that with each other as well. So it's very much kind of co-produced and taken on board the role of the participants and their knowledge. From a quantitative point of view, certainly we saw a significant reduction in the carer burden scales and improvements in well-being. And I think the qualitative information is can be extremely valuable there. And just people did enjoy that small group and the peer support that came with it. People did feel that they got that understanding of dementia, and they learned about different technology. Everybody bought an item from the group. Not from me, but they went off and bought it, and it was quite interesting. People were coming back, and I would recommend places where you could buy the items, and people were able to come back and say, well, Claire, I found it cheaper on this website. And so again, that was me getting that knowledge from people and learning from people. And also people went and bought different items and recommended that we would consider these for future groups. So it has prompted that, again, taking that expert knowledge on and developing the service using the knowledge of the people involved. Some people did ask for potentially maybe having longer periods to trial different items, like the GPS watches or items. They just would have them for a week, and they felt that some of them were a bit tricky to get to terms with, so it would be useful. So we've taken that on board then again as well. So that is the whistle stop tour to our assistive technology group in Sligo. It's a lovely group to do. I really feel I learned a lot from it, and I look forward to getting back into it now. Unfortunately, we're not doing them at the moment due to the COVID restrictions, but we will try and overcome them soon. Thank you.
Thank you so much for that, Claire. Such an interesting presentation. While I am just opening up, I'll introduce Ger in a moment. Could you let us know, you were saying there some of the people bought items after the sessions. Anywhere in particular, or were there any items that were more popular than others?
Everybody bought the orientation clock, the digital orientation clock. And I think that's kind of in keeping with the findings from the memory resource room technology. There was that, and the other items, I think somebody got the key finder was what was quite popular. And the item that people bought that we didn't have, that we've gone on to buy, was an Alexa. Which they kind of came back to us saying, this does everything. So we've gone on and bought some Alexas now, and we use them kind of with the cognitive rehab program as well. And we've managed to purchase them to give out to people, just as a kind of as a tool for communicating people during COVID as well. We're using the Echo shows. So yeah.
Great, fantastic. Okay, thank you so much. So this is Conor Ludden, and Conor is going to be speaking about the perspectives of nursing home facility staff on non-pharmacological interventions for non-cognitive symptoms of dementia. So thank you, Conor.
Great, yeah, thanks, Sinead. I'll just share my screen now. Yeah, just as Sinead said, this is my project. So I'm a newly qualified occupational therapist, and this is my project. It's a condensed version of my final year thesis, which is titled The Perspectives of Nursing Home Facility Staff on Non-Pharmacological Interventions for the Non-Cognitive Symptoms of Dementia. So this qualitative research project was completed under the supervision of the Professor of Occupational Therapy in NUIG, Agnes Shiel, and in collaboration with Abiola de Mahid and Joanne Gallagher in the Roscommon North Galway Psychiatry of Later Life team. So just in terms of background, Pierce and colleagues estimate that there were approximately 55,000 people living with dementia in 2016 in Ireland, and that almost 75% of people in nursing homes had dementia. So the non-cognitive symptoms of dementia are also known as neuropsychiatric symptoms or behavioral and psychological symptoms of dementia, and these are listed on the left-hand side here. And then the common non-pharmacological approaches for NCSD management can also be seen here on the left-hand side as outlined by O'Neill and colleagues. So after contacting co-investigators and gatekeepers, it emerged that information being given to nursing homes from the Psychiatry of Later Life Service was becoming repetitive, and they were going to attempt to address this by means of a tailored educational app, which would cover areas such as staff training needs, pharmacological versus non-pharmacological approaches, and to give staff a source of knowledge and education for effective NCSD management. So the literature review made known the most effective non-pharmacological interventions, as well as outlining how these interventions should be used as a first-line approach for NCSD. But this is often easier said than done due to the gap between theory and practice, among other factors. So the need for a unified multidisciplinary team approach when working with people experiencing NCSD was also highlighted constantly through the review. So then, just moving on then to the practical side of things, semi-structured interview questionnaires were compiled and suitable participants were recruited. The interviews were meant to take place face-to-face, but due to restrictions imposed as a result of COVID, they had to be completed via telephone instead. So once informed consent was obtained from each participant, the interviews were carried out, audio recorded, transcribed fully, and analysed using thematic analysis. And then the themes that emerged after this analysis can be seen on the right-hand side of your screen here under the results section. So just the kind of areas highlighted included dementia training, staff that completed supervision and reflective practice, the impact of resources and the environment, as well as kind of the lack of resources in some places, the importance of client-centeredness and how nursing homes avail of the Psychiatry of Later Life service. So what emerged from the results, just to the next page here, what emerged from the results was that a shift of mindset is needed to avoid NCSD being labelled as challenging behaviours. Health and social care professionals, as well as members of the MDT, need to further their education knowledge in this area and trying to be as client-centred as possible when working with people with dementia, and just getting to know as much as possible about the person they're working with. As alluded to previously, non-pharmacological interventions should be used as a first-line approach and as targeted interventions rather than general everyday activities. And then communication is key for effective NCSD management, and staff feel that supervision, reflective practice, and further education would all be worthwhile in providing an effective and successful service. And then just lastly, as you can see on the right, the overall aim of this research project was to provide a baseline which will inform the development of a tailored educational intervention program for nursing home facilities, which will hopefully lead to a transformation of care and community. So that's my project, and I'd just like to thank all the staff at Engaging Dementia and anyone who was involved in this project, as well as everyone who logged in today to watch this conference. So thanks very much.
Thank you so much, Conor, for that very interesting presentation, and I suppose setting out the challenges of implementing non-pharmacological interventions, even when it's known that they can be so effective. So just while I am opening up the next presentation here, is there any other comments that you'd like to make in terms of the next step? You were saying there about a training program maybe that this would lead on to.
Oh yeah, so this is just kind of, I suppose, background kind of gathering information for the development of this app that Abiola and Joanne hope to make available for nursing home facility staff. So this could be done like a kind of smartphone app, or just a resource there that would help the staff just kind of to make more effective dementia care, really. And so I suppose this kind of gives a bit of background info to what to include in this app and what would make it most effective for these nursing homes.
Okay, great. Thank you so much, Conor. Very interesting. Now I will introduce Bernie McGowan. And Bernie, if we can see Bernie here, Bernie is going to be speaking about prioritising the assessment of referrals to the social prescribing programme in the Mercer's Institute for Successful Ageing in St. James's Hospital. So, Bernie.
So good evening, everyone. My name is Bernie McGowan, and I'm Social Prescribing Link Coordinator in the Mercer's Institute for Successful Ageing since the 1st of May this year. So I'm going to talk to you for a few minutes about the social prescribing programme and how we prioritise referrals during the COVID-19 pandemic. I'd also like to start by just acknowledging the other members of the team, Dr. Mary Buckley, Dr. Gerard Boyle, and the project lead, Dr. David Robinson. Social prescribing, it's a means for health professionals to refer people to a link worker who can help them with their practical, emotional or social needs, and also to connect them to resources within their community. And these resources are often provided by the voluntary sector with a view to improving their health and well-being. So it's a non-medical response to health and well-being challenges. And studies have shown to date that social prescribing can improve measures of mood and well-being and decrease healthcare utilisation. So with financial support from Sláinte Care, the Mercer's Institute for Successful Ageing in St. James's introduced the first hospital-based social prescribing programme in Ireland earlier this year. There are approximately 40 social prescribing link coordinators, community-based around the country at present, who are receiving referrals from GPs and primary care teams. So the flow chart shows the pathway of referrals to the social prescribing programme, and patients are referred from the multidisciplinary team of doctors, nurses, and allied healthcare professionals that are working in medicine for the older person in the Mercer's Institute. And you can see from the chart here that approximately 59% of referrals at present are coming from the outpatient clinics. So once the patient is referred to the social prescribing programme, I will perform an initial assessment, which takes approximately 45 to 60 minutes. I prefer to do this in the person's own home because this is where the person is most at ease. People are referred because they are assessed both from a psychosocial point of view as well as their medical history or medical illness. I get to know the person during this assessment, where I find out about their lifestyle, what the person is like, what their likes and dislikes are, and also what's priority for them at present. And this helps to guide me to direct them to appropriate services where available in the community. Patients are signposted or they're socially prescribed into one form or other of a community activity or community-based service. And I follow them up for approximately 12 weeks on a weekly or fortnightly basis, depending. And this is usually through telephone calls. They're assessed, are reviewed again after about 6 months to see how they're progressing, to see if they need to be transferred into another program or another community-based activity. And they also may be discharged at that point from the service, or else they remain in the social prescribing programme. Since the programme started, I've collected data on all the patients who've been referred to the programme on a PSP database. So a review of the first 40 patients referred to the programme between May 1st, 2020 and July 31st was carried out. The mean age of this group was 79.8 years, 70% are female, and 55% of patients are referred due to social isolation and loneliness. In total, 35% of these people are referred to the programme have a diagnosis of dementia. Due to the closure of so many of the community-based services and activities for older people at the moment during this pandemic, it's been more difficult to discharge people from the social prescribing programme, and this leads to longer waiting times for new referrals. When prioritising referrals, certain things need to be taken into consideration, such as the presence or not of a home care package and the number of hours included in these home care packages. Irrespective of the circumstances, people living alone with a dementia or with a family member tended to be prioritised over people without dementia. And there are many reasons for this. Namely, stress of family members or carers either living with the person or trying to look after them from a distance. Concerns in relation to their safety, their dietary intake, and their lack of physical exercise. Lack of cognitive and social stimulation for the person. Lack of dementia-specific education and family members was also came to the fore, which resulted in challenges for family members and carers in supporting that person who's experiencing non-cognitive symptoms of dementia. So in conclusion, the number of referrals sent to the first hospital-based social prescribing programme in Ireland in a short period of time was an indication of the demand and value of this service. The study highlighted that when assessing the urgency of addressing referrals to the social prescribing programme, people living with a dementia in the community were prioritised. Social prescribing as a non-medical response to health and well-being challenges needs to continue to operate alongside other established medical referral pathways. And when prioritising the urgency of addressing referrals to the social prescribing programme, it is useful to have indicators, but it's also important to recognise that each case needs to be assessed individually. Thank you.
Thank you so much, Bernie, for that really interesting presentation. And hopefully social prescribing more and more now, we will be seeing it around Ireland. It would be fantastic. So thank you so much for your work and for that great presentation. I'll now hand over to Ger Matthews, our next speaker. And Ger is going to be speaking about improving wayfinding and orientation for patients for patients in a rehab hospital, a dementia-friendly approach. So, Ger.
Okay, thank you. My name is Ger Matthews. I'm a senior physiotherapist in Clontarf Hospital, and my poster presentation is about a project we've completed here to improve wayfinding and orientation for patients using a dementia-friendly approach. Just to give a little bit of background about Clontarf Hospital, we're a step-down facility that serves the acute hospitals in Dublin, providing orthopaedic and older persons rehabilitation. As I said, we're a rehabilitation setting, and we have noticed over the years that our patient profile had been changing, and more patients were presenting with symptoms indicating a cognitive impairment. And so our OT department have completed snapshot audits over the last 3 years, doing cognitive screens on our inpatients, and those audits have revealed that 64% of our inpatients had scores indicating a cognitive impairment. So knowing that, then a dementia care committee was formed in the hospital, and my colleague Emma Gannon presented earlier on the formation of that committee. And an important subgroup of that committee has been an environmental group. So that group completed an audit of the hospital using the King's Fund Enhancing the Healing Environment audit tool to see how dementia friendly the hospital was. And overall, we scored poorly, but the areas that were most in need of attention were those to do with orientation and promoting continence and personal hygiene. So we decided to prioritise those. The Irish National Audit of Dementia in 2014 recommended that ward managers and dementia champions should ensure that simple and effective improvements to the environment are promoted in all wards admitting adults, including appropriate signage and visual aids to support orientation and continence, personalising bed areas, and adequate space and resources to support activity and stimulation. And it's also well written that a decline in orientation limits a person's ability to perform their activities of daily living independently. And so this is really important for us in the rehab setting, where we're trying to improve a patient's independence to discharge them home safely. So with our statistics of the incidence of cognitive impairment in the hospital, and with the results of some temporary measures that we had implemented to improve orientation and wayfinding, we made a presentation to the board of the hospital to seek approval to make more permanent changes, and that was received well, and funding and approval was granted to implement permanent measures. So an Irish company was procured, and together we devised a new wayfinding schedule for the hospital using dementia-friendly signage that has been accredited by the Dementia Services and Design Centre in the Stirling University. And also we thought about purchasing large clocks that include the date, and to install 2 per bay so that patients on each side of the room would be able to see them, and also to purchase 1 orientation board per ward also. So you can move to the next slide, please, Sinead. So here are some examples of the permanent measures that have been introduced. You can see the signage is dementia friendly in that it includes both text and pictures on contrasting colours that are more visible to patients with dementia. They're also hung on the wall at the appropriate heights that have been recommended using a universal design approach. So the base of the sign would be 1.2 meters from the floor, which is lower eye level than normal signs, but to be more visible to patients that are elderly with elderly posture. You can also see an example of the orientation board there. So there's 1 of those on each ward, to include the day and the date, and also information on the season and the weather. And then there's an example of the large clocks that are more visible than what was previously in place, that also includes the day and the date. And there's also 1 of those in each day room as well. So the signs are just much more visible than what was already in existence. The previous signs were very reflective. They didn't have any pictures, and all the font was in uppercase font and lettering as well, which isn't recommended as being dementia friendly. So you can move on again, Sinead, to the next slide, please. So our results then, we did a re-audit again using the King's Fund audit tool in October, just last month, and we found by introducing the new signs and orientation boards and clocks that there has been a 23% improvement throughout the wards in orientation, and a 9% promotion of continence and personal hygiene. So we're happy with the results on orientation. There is more work to do to promote continence and personal hygiene. Those include more difficult measures to implement, like new flushes, different coloured rails for the toilets, and different colours for the toilet seats, etc. Interestingly as well, there has been a 2% increase in the mobility area of the audit tool, and a 9% increase in meaningful interaction as well. So that was a coincidental finding as well. So that's the presentation. Any questions, my email is there, and thank you for your attention.
Thank you so much, Ger, and great that we got technology to work anyway for us. So thank you very much, and really interesting to see meaningful activities and occupation being that kind of unexpected byproduct. Really very interesting talk. Thank you. And the orientation clock again that we saw coming up earlier on. So before it's coming up to 6, so I'm afraid we're going to have to finish up without a Q&A. If anybody has any pressing questions, if they just pop it into us quickly, maybe we can come to one, but we can show there was a request to Brian for photos. So Brian has very kindly put them together for us here, and we'll do a screen share. So whoever asked us for the photos, here we are.
Just pop them up there. So on the top right is the kind of Christmas time last year, where that's the nice fireplace that was donated and the background wallpaper. And just to say, I didn't mention in the presentation that we really didn't do this as a sole entity within the ward. We tried to make the wards dementia friendly as well, through signage and through dementia friendly clocks and wayfinding and things like that. And also we implemented having a bus stop with some bus seats. I don't know if you can see it there in the picture of Hoth in the background, just as a distraction and something to be able to create a conversation with and distraction with. And we got old pictures. And down on the bottom left, we created a little snug, which we got the idea from Connolly Hospital. So that's a little quiet area if patients just wanted alone time or herself and a carer or a family member to go in. And we've lovely pictures there and just very calming environment with 2 little seats and a coffee table. And then we have just old pictures around the ward as well. And we have a dining room table and chairs within that sitting room there, just to make it really homely. and we're getting reminiscence therapy and boxes and fiddle blankets and all those things to make the whole area very dementia friendly and calming and homely.
Okay, thank you so much, Brian. Thank you for being so responsive. After that query came in to show us photos. Photos are absolutely wonderful. So thank you everybody for your presentations. Such a span of work, but it was interesting to see that there are kind of common themes and threads coming up through many of them. So thank you so much. This is going to be recorded, so it'll be available afterwards to people who haven't had an opportunity to see it now. I'm just going to log a poll before we go, just to get a sense from people who are in the room. And so we're finishing up. This is the end of the last session for day one. Tomorrow we will kick off the day with 2 sessions. So tomorrow, just like today, we'll have 2 rooms going all day, and we'll have psychotropic medication and dementia in one room and creative arts in the other. So those sessions begin at 9 a.m. tomorrow. And like I said, we're on Twitter. So if anyone uses Twitter, do feel free to join the conversation there. So thank you so much, everybody.